My name is Rick Eisensee. I'm the clinical consultant for the Shanti project. And this morning we're going to be talking about a number of clinically oriented issues in terms of our volunteer contact with our clients. Our first speaker is Dr. Tom Smith, who's a psychiatric consultant for all the alcohol-related programs that are city-funded in this town. And he's also director of the Alcoholism Treatment Center at San Francisco General. Tom?
Good morning. I have two topics today. One is on alcohol and drug issues and the other on sex. So I call my talk Sex, Drugs, and Rock and Roll. And by that I mean safe sex and less drugs and getting high and having fun, perhaps with rock and roll or with other musical pleasures. I'm a psychiatrist, and I've been working for many years in the field of alcohol and substance abuse. And I've also worked with the city around sexual risk reduction issues. And this was before the AIDS crisis came along. We were very interested in risk reduction with STDs. I'd like to stress that we in the gay male community have three different crises, not just one. I mean, there is the AIDS crisis, but there's also another alarming crisis, the sexually transmitted disease crisis, and a third crisis, which is very related to the other two, has to do with alcohol and drugs. Well, why should we be concerned about drugs and the issue of AIDS? First of all, there's a high incidence of people with AIDS that have used drugs. We certainly know about the 17% of people with AIDS that are IV drug abusers. About 15% of these of gay people with AIDS are reported to have IV drug usage. Now, in the October 80 CDC study, a high percentage of the people with AIDS in that particular study were using poppers and other substances of abuse, and most probably a high use of alcohol, even though most of the controls also used alcohol. So that was not something that was remarkable at that particular time. We also know that there is a great degree of alcohol and drug usage in the gay community in general. And we feel that around 1/3, from various studies, about 1/3 of gay men, urban gay men, are alcoholic, and this possibly goes up to a half in some particular communities. There's several studies, and there are fewer studies about drug usage, but the studies that we do have show that there's an alarming high degree of other drug usage in the gay community. Most gay male druggers are polydruggers. I mean, it's a way of contouring your drugs, you know, your downers and uppers and hallucinogens. A third reason for being concerned is that a significant number of people with AIDS are turning to, and sometimes returning to, substance abuse. And this is interfering with their recovery. And I'm going to say more about that. Alcohol and most substances of abuse have deleterious effects as far as the immune system is concerned. We've known for a long time that there is a higher incidence of cancers among alcoholics. And with some particular cancers, it's like 12-fold. We've known for a long time that alcohol and grass decrease the immune system. We've known for a long time that alcohol and many other substances of abuse are associated with increased ability to have various infections. We've also known that alcohol and other drugs of abuse decrease a person's judgment, especially in sexual situations. But as the person becomes addicted to these substances, it decreases the person's judgment in nearly every area of the person's life. So there are a whole lot of reasons for being concerned about alcohol and drugs in people with AIDS and in the gay male community in general. In general, alcohol and drugs act as a cofactor, most probably as a cofactor in producing AIDS, and that alcohol and drugs either slow or impair the recovery in AIDS. Okay, the drugs that we're talking about is alcohol, which most probably is our hardest drug, even though it's usually not thought of in that way. Grass, poppers, speed, cocaine, and all the other substances that we usually think of as recreational drugs. Alcohol and drugs can also interfere with the person's interferon treatment and various treatments that the person with AIDS may be undergoing. There have been people that have had to stop their interferon treatment because their liver had become sick, most probably from booze. In counseling the person with AIDS, the counseling with the person with AIDS is much like the counseling with anyone with an alcohol and drug problems. It's much alike. And I'll talk about some differences. First of all, there's assessment. That the person has an alcohol and drug problem. Especially with alcoholism, the person is not going to be telling you that. Or if you do say something about alcohol with a person in denial, usually the person says, "Oh, I don't have a drinking problem, you know, I just drink a little bit," or "I almost never drink." In other words, there's a tremendous amount of denial. So assessment is very important in knowing how to assess so that you get an accurate picture of what the person might be drinking or using. One assessment tool is self-assessment, and this is usually in the forms of questionnaires. And in the packet in the back, there's one particular questionnaire. And I feel that with all gay men that are presenting in any kind of health situation, that perhaps they should look at this and fill it out. There's a comparable self-assessment questionnaire for drugs, drug usage. The questions mainly have to do with is the person using alcohol and drugs to excess, and are they having negative consequences to this? A self-assessment is a preferred way of working with people around alcohol and drugs because it includes the person in the process of trying to come to some decision about whether they do have an alcohol or drug problem. It's also an educational tool. There are some things we can do around history taking with alcohol and drugs. One is to find out how much the person is using. And with alcohol, one way of doing that is to ask which brand does the person drink? What types of alcohol do they drink? When do they drink? How often do they drink? How much money do they spend? In other words, we in alcoholism go around the whole issue of history taking from many different directions, because often the person is denying and wants to minimize their drinking because there's such a stigma on alcoholism. The person may also be telling you that they have an alcohol or drug problem by just the fact that every time you're around them you smell booze, or every time you're around them they're offering you a joint, or they keep alluding to substance use. And this might give you a little clue that maybe this is a person that is using substance abuse as coping mechanisms. So smelling is a very important part of assessment. Now, if the person is in denial and is saying, well, I don't drink very much, then there are many different ways of getting around the denial. If the person says, you say, if you're asking about the amount that the person's drinking, and they say, oh, I rarely drink, and you feel that the person is just really denying this and is really shut off, there's a wall, then multiply everything they say by 2 or 3. Most probably will give you a more accurate assessment. And I'm not just saying that in a flippant sort of way. There have been many studies to show that this does give you a more accurate assessment if the person's in a tremendous amount of denial. I usually give the person that's in denial a lot of information and talk about that this is a problem maybe that they aren't having, but that a lot of other people are having. And I start telling them about how this does affect negatively the immune system and their disease process. So I still give them the information even if they wish to continue using denial. And we as counselors get more than one chance at saying something like this. If the person gives you an indication they don't want to hear, you can give some information about as much as they wish to hear and then shut up. And then maybe later on, maybe bring it up again. And then see if they are able to hear some of this information. I can still give information about referrals to the person, even though they're saying, you know, I don't have an alcohol and drug problem, even though you've been hearing through the grapevine that they really are drinking a whole lot or using a whole lot, most probably as a way of coping with pain and weakness and many other things. I can still give them information about referral. I can still give them support. And one of the main things that I can give them is hope. And this is one of the things that's rarely thought of in connection with alcohol and drugs. Most of us are taught in some sort of way that alcoholics is just a downhill process. And that's not true at all. I think it's very helpful to know some alcoholics that have recovered, especially ones that have lost a whole lot. Maybe also knowing some that have lost little, what we call high bottom people. But to know some of these stories about people with AIDS that have had drinking problems and have done something about that. In other words, that gives a person hope that they can make positive change, that is possible. Sometimes the problem in counseling with alcohol and drugs is a problem of the counselor, and it has to do with attitudes within ourselves, especially if we are conflicted ourselves about substances of abuse. Now, some of us have come from alcoholic families or drug-abusing families, and you know, if you went through a violent childhood or something like that, you most probably are conflicted and possibly have learned some negative ways of dealing with it, or some ways that are not the most helpful in a counseling situation. In alcoholism, this is so frequent with alcoholism counselors that this has been called co-alcoholism of counselors, where we are doing something as counselors to possibly increase the person's behavior or condone it in some sort of way. So when we do any type of counseling around substance abuse, usually we have to be very careful that we're not overdoing for the person or we're not coing them. Taking a look at the counselor taking a look at their own substance use usually is very helpful. And the reason is that when you start counseling a person around substance abuse, usually you do start thinking about your own substance use and your own use of denial and resistance and rationalizations and such. Another question that comes up for counselors is, what is substance abuse? Now, certainly, a person that drinks 1 glass of wine a month is not a substance abuser, most probably. A person that might toke on a joint very infrequently most probably is not a substance abuser. So there's something called use and there's something called abuse. And abuse means that the person is having problems, whether they're physical problems, emotional problems, social problems. There's some kind of problems associated with the use of the particular substance. Now, for people that have gotten into a compulsive pattern with substance abuse, then there's almost only one solution, and that is total abstinence. And there have been too many studies and too much information for us to think otherwise. That if the person has had a drinking alcohol problem, and this has become a compulsive problem with them, then most probably they're not going to be able to control the substance when they return to it. And this is a good point when you make an assessment, because when we make a history, we want to find out the person's past history with substance abuse, because that might say something about what might be predictable. Say the person with AIDS comes down with PCP, is in the hospital, feeling very weak, and then a month or two rolls by, then if the person has a history of chronic alcohol abuse, the person may think of that as a coping mechanism when they are feeling depressed. Now, the problem with that is there's a question: why not let a person that is chronically sick, why not let them drink? Why not let them use? And the answer, I think, is fairly simple, and it's because it decreases the value of the person's life. Alcohol and substance of abuse directly affect the brain and increase depression. They decreased irritability. They decreased low self-esteem and despair. I mean, all of the things that the person is wanting to counter in their illness, alcohol and drugs are increasing those particular qualities. So to me, it's so we come up with the same problem with elderly people. You know, someone says, oh, my grandmother drinks a lot. Well, why not, why not let her drink? I guess the question really is, why should she make some kind of change within herself? And I believe that it changes the person's quality of their life. Often what happens when a person quits drinking and drugging is that they usually start feeling better, mentally and physically. Certainly, a person in a recovery process should have those particular kinds of feelings. Sometimes we as counselors become overzealous, and we want to help everybody, perhaps too much. And the whole issue of substance abuse may be one that might take time. And even though you might know that the person's drinking half a quart of hard liquor a day is not helping their recovery in AIDS, that still this person is going to have to perhaps come to grips with that on their own and have to change at their own pace. That doesn't mean that we don't still provide support. We do. We would continue with support and with hope-giving and information about referral. But we also need to honor the person's value systems and the person's ability to change. I mean, a lot of internal work has to go on too within that person to make some kind of change. Sometimes the person that is, say the person with AIDS that is using substances, they're using it to get relief. I mean, this is the main reason why everybody started using substances to begin with. We didn't use substances because we wanted to commit slow suicide, or, you know, we wanted to wreck our health or our lover relationships, something like that. We started because it was fun and because it produced relaxation. It got us spacey. You know, we did it for a lot of good reasons. There are positive results of substance use. But over time, the substances of abuse can cause negative problems. And the person with AIDS that's having pain and depression may turn to alcohol and drugs as a way of coping with the pain and despair. What this means is that that person is saying to us, I'm having pain, physical pain, I'm having despair, and I'm using substances as a way of dealing with that. They still need treatment or counseling or support around the issues of pain and despair, but perhaps non-chemically. So there are other ways that we could work with the person around issues of despair, and also some things that the person can do non-chemically around issues of pain. In general, the treatment approaches in alcohol and substance abuse counseling has to do with taking responsibility. We definitely believe that the person is going to have to ultimately be responsible for making some decision about their substance use. And as long as we're doing too much, we're kind of taking away from that person's responsibility. This is an extremely important factor in substance abuse counseling. Now, I feel that there are some exceptions to that, especially when the person becomes organic in their head, sick in their brain, or when people are extremely ill. Then perhaps we do need to do a bit more for them. So it may be that we may need to be a bit more active. And we see this a lot in substance abuse, especially when the person becomes very ill. Then we as counselors need to be more active. But it's kind of like in other teaching situations. At first you might do a lot, but in time, as the person becomes more autonomous and assumes more responsibility, then we start doing less and less, because we want the person to take on more and more and more responsibility. So some people that are really ailing with AIDS, then we may need to do more to go in to work with them around substance abuse issues. Another important approach is action. Now, something is going to have to be done. There's going to have to be some kind of activity taking place around stopping substance use. And it usually means that the person stops substance use, but at the same time they've got to become active in many other ways. Because what's happened is that substance use has taken up a lot of time usually, and it's functioned for a lot of different reasons, socially and this sort of thing. So when the person quits drinking, it means that the person needs to become active socially, especially socially. It means that the person needs to have increased time structuring, have to plan out their day. What I'm seeing is that people with AIDS that are using, sometimes the problem is that they're going to their room and not being around people. And that's a kind of a dangerous situation for recovery in general. So action is another important approach. People need a lot of support around changing with substance abuse issues, because it's not easy. I mean, a lot of times the person's substance use has been there for a very long time. And this is an ingrained pattern. So they need a lot of support from us. They need information about what substances do to the immune system, what substances do to the body in general, and they need information about referral. They also need help around referral. Just saying to someone, oh, you know, I think it's a good idea if you go to AA, might not work as well as you going with them. Some of the most important referral, I think, is NA and Narcotics Anonymous and Alcoholics Anonymous. And in the back of the pamphlet on the green sheet, one of the green sheets, there's an AA meeting that is listed for people with AIDS. There's also a list of other referral resources in the city, and we're working on other referral resources. Sometimes a person that is drinking and using needs confrontation. In other words, every time you see them, they're drinking or you hear of it, and you've been silent or you've been saying very little, and there comes a point where you almost feel in your heart of hearts that you really need to say something to this person, that they're endangering their life. So I feel that confrontation is very important, but it has to be done with a tremendous amount of respect for the person and remembering that the person needs to be responsible. It's their choice. So it's sort of a two-pronged approach. At one hand, you're confronting, and at the other hand, you're being very respectful of the person. Another major treatment in alcohol and substance abuse is called holism, or the wellness approach. And this is the same approach that's used with people with AIDS, is that we know that recovery, whether it's in alcoholism or with AIDS, most probably is increased, improved by the person doing various things to improve their body, such as stress reduction, getting enough sleep, eating well, nutrition, having sex. All of these are wellness approaches that's used in substance abuse. Last night, a friend of mine with AIDS called, and he said that he tried to kill himself, and he's in a lover situation, and it was an aborted attempt. And he's called several other times, but I hadn't heard from him for a while. And in his lover situation, he's been extremely afraid of giving something to his lover. In fact, he feels that he has. Now, his lover seems to be fine, you know, but he's convinced that he's done something extremely wrong. Their relationship had started off with a lot of really happy, joyous sex. In fact, this is one of the things that kind of brought them together, and with some other interests. But they had this very joyous sexual relationship, and this went on for many months. And then my friend started becoming weak with night sweats and such. And he started worrying, and sex stopped between them. And his lover is still around. He says to his lover, you know, you can leave if you want to. But there's no closeness. And there's no touch and sensuality. And to me, the essential difficulty here is a tremendous feeling of guilt that's connected with sex. I mean, he said on the phone last night, he said, I guess everyone regrets their sex life. Well, I don't. And I was saying that, well, some people do. It seems that though a lot of people are very concerned about how to change their sex life so that it's more positive, or so that it's safer. And it sounds like he really regrets his past sex life. And so it's become something that is a black hole for him. There's a tremendous amount of guilt associated with it, tremendous amount of worry. He thinks about it a lot in a very negative sort of way. It is so easy for us to see sex as bad, as the culprit. In a lot of situations, say when there are political goings-on in the city, often the politicians will say, what's wrong with this town is the whorehouses, let's close all the whorehouses. This is all the corruption and violence in this town. And I think that we've been taught that sex is the bad guy. That when things go wrong, that most probably it's our sex life. Now, I'm a sex counselor, and I see lots of people around sexuality issues, and that sort of homophobia, 20 more minutes, is there, lurking around. I think that the first principle in sex counseling is to be positive, to be sex positive, and to be gay positive. And when we hear a lot about how bad gay people are and how bad our sexuality is, how much we can't have relationships, how awful we've been, I really try to let that go in one ear and out the other and try to turn it around and see if this applies in general to people. And often it does. We have 20 more minutes, so I'm going to skip over some things. I usually think of sexuality in terms of holistic aspects. In other words, sex has to do with our body, our genitals, our head, our hormones, and all of those things. It also has to do with our brain. Our mind is our most important sex organs. In fact, if we didn't have a whole lot of this, we would still have a sex life because of our brain. And this certainly is true with people that have had transections of the cord. That a person can still have some sensuality and certainly sexuality. Sex also has to do with other people, often. With their spiritual sides. There certainly are values associated with sexuality, and there are lots of these, and opposing opinions. And there are aspects of sex that have to do with drugs, getting high, associating that with sex and altered consciousness. Okay. One part of sexuality counseling with AIDS has to do with risk reduction. And I like to look at risk, that there are levels of risk, that there's biological risk, and it has to do with the transmission of an agent. But there are also risks such as psychological risk. Now, a person that looks at this picture is not going to have any kind of biological risk looking at this picture. But some people would feel that this would produce some kind of psychological risk. Or they might feel that this produces some kind of existential risk. So there are levels of risk, and especially on the existential level, where there are people that have many different viewpoints around sexual behavior. Okay, sex has been divided into sexual risk, high-risk behavior, moderate, minimal, and very low sexual risk behavior. I'm not going to go into this because I feel that most of us already know this. But in taking the various sex risk reduction guidelines, I feel that it's very important when you do any kind of sexuality counseling to be very aware of those guidelines, to be aware of what theories those guidelines are based upon, and to also know the theories that the person has, because their theories may have something to do with the different decisions that they'll make around sexuality. Often when a person hears about risk reduction, this is supposed to be bargaining, but there is a bargaining process that goes on, and the person wants to know is, can I suck dick halfway and maybe not swallow the cum? Is that safe? In other words, there's a bargaining. The person is, it seems, in their head is trying to figure out what's safe for them. Now the thing is that we actually don't know what's safe. You know, that information is not available to us. But what we do know is that we have to make the best decisions for ourselves right now. And when a person says, what should I do? I say, well, the best decision I've made for myself right now with information is blah, blah, blah. And I give information to the person so that they can make the best decisions, and I refer them to all the different risk reduction guidelines, which they can read just as well as I can read them. Okay, and the person ends up with some responsibility or action. There's a lot of concern around the issues of condoms. Now, earlier I said that we have 3 crises in our community, and one of them is sexually transmitted diseases. And if you think that condoms are chicken wire that these tiny little viruses can drop through and give you AIDS, then I still believe that there are studies to show that condoms are preventative for various sexually transmitted diseases. So we still have a very good reason to recommend that people use condoms. One thing I'd like to say about the guidelines, risk reduction guidelines, is that these guidelines are for all gay men and bisexual men, not just for people with AIDS. And there are several reasons for this. One is that there's possibly a carrier state. There's some information that says that that might be true. And also that there is this possible long incubation phase. And if this is true, then this is a type of safe sexual activity that all gay men should be having, especially in new situations. So the people with AIDS should not be targeted. I mean, that's a smokescreen. That this is information for all gay men. Okay. Okay, I think another part of sex counseling has to do with how people make changes. And people make changes in a lot of different ways. Some people have used willpower and they say, I'm never going to go to the baths again, and then they stop totally. But a lot of people, it takes time to adapt for those internal changes. And so the person might make a decision, and within a period of time, their behavior changes. Some people use a guilt cycle. The person says, I'm never going to do this again, and then they feel awful after they've done it, and then they go out and do it again, and they feel awful. I mean, this is usually the pattern with compulsions. And so the person needs to get out of that particular guilt pattern, sometimes making goals over a period of time and honoring the person's pace. Different way of getting out of that guilt pattern, and there are other ways of doing that. I think one of the main ways that we change, though, is that the community is changing, and that we find out that it's okay to start talking about health issues on the first date and that sort of thing when we first meet each other. And it's becoming increasingly okay to only jack off or to do things that are safe. So I don't feel that it should be left up to just every individual, but also to the community to make some positive changes. Another thing that we saw in the film is that some people, in giving up high-risk behavior, can still use fantasy. I mean, fantasy is very safe, so that the person that likes to rim, they still can fantasize about rimming while having sex. And to have safe sex doesn't mean that we quit having fun. I mean, that It's like looking at it from the glass as half full rather than the glass as half empty. I mean, we still can have intensity. We can still have really intense sex. We can still have really far out sex. We can still really get into our partner. We can still have tremendous intimacy and cosmic sex. I mean, if we just look at the restraint end of it, we can also look at that that there is a whole lot that we can do using our own creativity. AIDS affects the person in many different ways, this person with AIDS. The weakness and pain, that all of this has to do with sexuality. Weakness, the person may feel so weak that they cannot have sex. However, we know that all it takes is the energy of walking around the block. Now, this is information we've got from people with heart attacks, sexuality issues with people with coronaries, is that the person only needs that amount of energy to have a sexual life. And sometimes the person knows that maybe they don't have to come, that there still can be touch and sensuality and feeling good without a whole lot of expensive energy. I mean, a lot of us have been trained, you know, it's got to be faster and harder to be better, but there may be some other ways of having very enjoyable sex that perhaps is slower. 5 minutes, huh? Okay, body image concerns. The person that has visible KS spots. Now, one man was very concerned about having sex with other people because his lesions on his legs. What he chose to do was to wear pants or to stay covered. Some other people, though, never do like their lesions, and they have not come to terms with that, and perhaps that's okay. Perhaps the person has that right. So some people will have a different feeling about their changing body image, and that they can work with their partner, or their partner can work with them around these issues. And some people will continue to feel very badly about this. There are concerns about catching things from other people and decreasing or diminished sexual desire. Now, what I'm seeing is that sometimes this diminished sexual desire is mainly related to two things. One is depression and despair that the person is having, and we know that those can be highly related to sexual problems, and medication and drug usage. I mean, most of the medicines that the people are on decrease sexual desire. And I think that the person needs to know that so that they don't think that it's a problem within them, but rather that it's a side effect of the drug, that when they quit taking the drug, that their sexual desire will return. Another big problem is availability of partners. You know, if you have AIDS, where do you find partners? And some people are finding partners in bars. And some people are too afraid to go to bars. Now, a bar is usually a place where you go in and acceptance and rejection happens like that. In other words, the person may need another milieu where they don't get into a situation where they have to be accepted or rejected immediately. Maybe there are other ways, maybe through parties, through friends, through clubs, activities, groups, where a person meets people more slowly to become accepted. But many of these different problems that come up around AIDS and sexuality can be dealt with. Okay, the last part. These are some common problem situations that come up around the issues of AIDS and sex. And we've already talked about some of them. I'd like to talk a little bit more about handling sexual impulses, because this seems to be a problem. The person, you know, the phase of ailing from the AIDS is decreasing. They're feeling better, and they're ready to go out, and they're expressing difficulty in dealing with their sexual impulses. Well, one way of working with this is the person to perhaps masturbate. Now, sometimes that works and sometimes that doesn't. That doesn't fulfill what the person was needing inside. The person's having an urge to go downtown, have sex. But the person can take a look at what needs do they want fulfilled. Is it to be with people at that time? Is it to relax? In other words, a person makes an analysis of what they need, and then perhaps find that in some alternate way that can be safe. Sometimes finding it through sexual means. Another problem is how do you keep safe sex limits in the middle of passion? You know, you're kissing someone's nipples and you're headed downward. And one of the problems is that our ordinary state of consciousness is different than our altered state of consciousness. And when we have sex, we go into a right-brainedness, which is an altered state, which has more to do with flow and being with another person in a flow sort of way, rather than this more controlled, wordy sort of way. And as we do that, the value systems change so that we actually have perhaps a different thinking process going on. So one way a person can make those kinds of changes is to actually start thinking while having sex about some sexual limits and how they wish to do things while they're actually in the altered state. Another way is to talk about sexual situations with friends and such and see what friends are doing, so that when talking about sex you also kind of sometimes go into altered consciousness, and when you do that then you can make some changes that will carry over into the altered state. Altered state changes usually take time. If we say to ourselves, I'm never going to REM again, then that might not be getting over here. It may take time for that kind of message to get over to this side of the brain. Okay, I think we'll stop with that.